Okay, Jeff just logged in.
Hi, this is Marissa.
Hey, Marissa. This is Becky. Can you hear me?
Yeah, I can hear you.
Oh, okay. I'm presenting tonight, so I'm just kind of waiting for Jeff to log in. So hopefully he'll be here. If not, then I'll figure out how to log in and do the slides. So are you ready for another long night? I hope not.
I'm good for as long as it needs to go.
You're good. You're good. Have you ever done ski patrol before anywhere?
No. Have you?
Yeah, I have. Years and years ago, I was on patrol. Then I was away for about 18 years, 15 to 18 years. Yeah, so I just came back this year. Well, actually, it's been my second season. And my daughter, Van Bennett, that you see on the screen name there, that's my daughter. So we've been back for we've been back for 2 seasons. So she skis, and I'm no longer a skier. So I just enjoy working in the patrol room.
Okay.
I'm going to try to find that email. Can you still hear me?
Yeah.
Okay, because I'm trying to find this email just in case.
What's wrong?
In case Jeff is.
I'm going to dial in.
Okay. You can't do that over the computer?
I probably could, but then I can't walk around.
Oh.
Did you find it?
Yeah, I'm just writing it down now in case I have to. How's your studying going, Marissa?
Good. I'm still catching up on some chapters, but it's been interesting.
Van Bennett.
Van just signed on.
Hi, and I'm on the call too. Can you guys hear me?
Yeah, I can hear. Can you hear me?
Yes. Marissa, how are you?
I'm good. How are you doing?
I'm good. My name's Van. I live in Austin, Texas.
Hi, Van. How's it over there?
It's hot.
I bet. Yeah. Pretty hot here, too, but it's probably hotter over there.
Where are you?
I'm in Alamogordo, New Mexico.
Oh, okay. Yes, it probably is a little warmer here, but that's all right.
I don't know how long it should give.
What do you do in Alamogordo, Marissa?
I'm an environmental engineer at the base.
Oh, okay. Great.
Yeah.
Mary Jeff.
Hey, this is Jeff.
Hey, Jeff.
Hey.
Hello.
Looks like you guys beat me.
A little bit.
That's what retirement does for you.
I'll have to try it.
Yeah, it's pretty good.
I'll be there in about 35 years.
Oh, don't wait that long. You'll be dead.
Pretty much.
Now, are you going to turn it over to me?
Oh, sorry. Let me try to figure that out. Aha! It's easier than I thought.
Okay.
See if that works.
Okay.
Notice or something?
How do I get my slides?
I think I see your screen. I see Google.
I see Google.
I think that's
Now
yours.
I just want my slides.
Oh, okay. Do you have them saved on your computer?
I do on my Google Drive.
Oh, okay. So go to drive.google.com.
I have that as an app. Can I use that?
Sure. Yeah.
Okay. I'm at that now. I'm in my Drive right now.
Okay. Oh, it might be. Do you have two screens?
No, I do not. What do you mean?
You don't have two monitors?
No, I do not.
Oh, because we're just seeing Google.
Well, I can open the first two chapters and see if anything else shows up.
Okay. You might. Let me see.
They don't see him.
No, I don't see them, and I forgot how we did it last year.
How do I get my controls back? Aha. Okay. So you should have like a button on the controls that looks like a play button, I think, or it might be a pause button now because I think you're already sharing.
On the free conference call?
Uh-huh. And when you click that, it'll ask you what you want to share. So you can share your whole screen, or you can share a specific application. So I would just share whatever's on your screen. That way, whatever you're seeing, we're seeing.
Okay, I don't account preferences. Let me see. No, I don't see what you're telling me I need to have.
Here, let me see if I can take control back, and I'll show you on my end.
Oh my God, I'm sorry.
Don't worry. So let me. Stop presenter. I think that should be off. Let me see. Okay, so. Oh wow, I got a whole bunch of stuff open. Oh, I don't know what I just did. There we go. Sorry, give me one sec. I probably should have cleaned up my, oh my gosh.
Yeah, I'm
I
not
probably
seeing.
have 100 windows open.
Oh goodness.
Yeah. I got Google Maps open. Whoops. Nope, I don't want that. Get to Google Drive.
Let me see.
I'm almost there.
Okay.
And I think what I could also do is I think I can just give you control of my computer. So worst case, you could just control what I'm seeing. But okay. So free conference call, and we'll go share. Oh, are you seeing my screen?
I just see white.
I just see white.
Play.
Oh, you want to go back to that?
Start now.
Mm-hmm.
So I clicked on it looks like a monitor with the sharing icon.
Yeah, okay. Now, you know what? I think where did you pull that up, Van? That just popped up. I saw that monitor with the sharing icon.
Can you see my screen now?
No.
Really?
Yeah. Oh, I can see. No, I think I'm seeing my screen. I'm not seeing Jeff. It popped up there for a minute.
Let me switch to Google Drive. Are you seeing Google Drive now?
Now I'm seeing your screen.
Okay. So let me switch back to free conference call. So see this?
Yes.
Unfortunately, I don't have a mouse, so I can't really point. But starting at the top, you have this. I believe that's so I could send it to a TV, which I don't want to do. this shows me participant.
Correct?
And we can, the chat is this little blue thing. Oh, okay. That's your chat window. So make that go away. I'll do it quick. I could mute you by clicking the microphone, and then I'll take you off. Okay, you're good now. Now, if I want to pass control, I can click on you, the 3 dots, and then I can do make presenter.
Make presenter, okay.
Or I thought, that's interesting. I'm not sure why I say request control, but I thought I could give you control. So we could do that. Now the telephone I'm not going to do because if I click that, it'll hang up.
Okay.
You'll be able to hear me. The next one is like, see the computer monitor with the sharing?
Yes.
So that's, when I click on that, it gives me my options for sharing my screen.
Mm-hmm.
And then let me go someplace where there's more light. There, next to that is a video camera. And so now you should be able to see me.
I do.
So I'm going to turn it off, though. And then the last one, if I click that, I'll leave the meeting, which we don't want to do. So let me see. Were yours saved on the OEC drive?
You know, I just have them on my drive, so I don't know if they were saved on the OEC drive or not.
I have yours from last year.
Those same ones I have.
Oh, okay. No changes?
Yeah.
Okay. So
Chapter
I can go
13, 14, 15, 16.
Okay, so if I go in structure, lecture slides by chapter. Oh, wait, because that's going to be one by one. I know I had yours. Oh, wait, I think it's under archive. 2017. Come on. Ooh. Boy, I thought I had them. I mean, I've got the original NSP slides. I don't think I have them the way you edited them. Oh, lectures? Maybe.
It would have BA.
Oh, here we go. This would be session. No.
13, 14. Oh, I don't know what session this is.
Does that look right?
There, yeah, that's my slides right there.
Aha. Okay. So let me try it. Oh, there's BA chapter. Okay.
Yeah.
Which one are
13,
we
14, then 15, and then 16.
Is it the one with the kid on it?
Yeah, start with the one with the kid on it.
Okay. So then let me see if I can just pass control to you. Oh gosh, I forgot my password.
Is it Mini Dole?
No, because I think it's my office password.
Oh, you're as bad as I am.
Let's try that. Uh-oh. Aha.
There we go.
Okay. So now, ooh, the thing is I'm used to doing this on a computer.
Yeah, I'm on an iPad, so.
Aha, there we go.
I got to figure out how to advance my slides too.
So let me go back to, whoops. Let me go to pre-conference call. Now let me see if I can give you control so you can just advance it. Request control. Oh.
Are you sure to take control over this PC?
Okay, see if you can do that. Do you have the same icon with the people on it?
With the people on it?
Yeah, this one.
Yes, I'm seeing it. Yes.
Can you click on OEC Ski Apache, and then the menu, and then when you do that, I think you'll see like when I click on yours, and I have
Okay.
request control.
I am tapping on it. It's still showing you. Oh my gosh.
So
that's the screen, so I can't really do anything to it.
Oh, do you see in your app, your free conference call app, do you have this icon up here with the people?
Yes, I do.
And can you, if you click that and then click on OEC Ski Apache, you should get the hamburger menu, the 3 dots. And then can you click that and click request control? Huh.
Oh, but this might be easier for you to just log in as control.
Yeah, if you can open the slides on Google Drive, you could do it that way too. I could just make you the presenter. Otherwise, we'll just go ahead and just tell me when to advance, and I'll
tell you what. Why don't I just tell you when to advance?
Okay. I'm going to mute myself.
Okay.
Let me think. Oh, here we go.
Okay, are we ready?
Yep.
Okay. Marissa, you were so well prepared, so I hope you're well prepared this time. I won't pin your ears against the wall, but we're going to start with Chapter 13 in respiratory emergencies. So I like this picture, and I put it up because it kind of answers 2 questions. Why would you think I chose this picture?
Not sure. I mean,
I know. It doesn't show it, but I liked it.
Okay.
Yeah, I liked it because the tongue is the most frequent cause of a respiratory obstruction. And in a small child, the tongue is bigger than the airway. So I just thought it was kind of a cute slide to go ahead and put up there and kind of show a point there. Advance the slide. Jeff? Okay. So I won't go over all of the objectives, and I know objectives, but I like for you to pay attention to the objectives only because you're going to, embedded within the objectives really are a lot of test questions there. So you're going to need to know these definitions of diffusion, dyspnea, respiration. You're going to need to be able to understand the major anatomical structures of the lower airway. What is the primary muscle of respiration? That's a test question right there.
The diaphragm?
The diaphragm, very good. And accessory muscles of respiration. And we're not going to spend a lot of time on physiology of breathing, but it goes back understanding diffusion, okay?
Okay.
Go ahead, I'm sorry.
No, I just said okay, that's all.
Okay. Jeff, advance. Again, further objectives. An important respiratory emergencies are probably going to be the most frequent patient that you're going to see on the mountain. Some are going to be simple altitude sickness, and some of them will not be simple respiratory issues. So you really need to be able to understand what is normal breathing, what is abnormal breathing. You need to know the rate, test question here, needs normal breathing rates for each individual and each of the age groups. And we just kind of talked about the most common cause of airway obstruction when we looked at that little boy in the picture. Advance. So we'll go over symptoms of acute distress, and we'll touch lightly on some of the symptoms of respiratory emergencies. So you look at asthma, COPD, and you're going to go, do you know what COPD is? Chronic obstructive pulmonary disease?
I think it was mentioned in the book, yeah.
Yeah, it is mentioned. We'll briefly touch on that as well and some of the other topics there. Advance. And we're going to go over how you're going to begin assessment of your patients with respiratory difficulty and be able to describe and demonstrate the appropriate treatment of a patient in respiratory distress. Now, I put this picture up because you see a little baby in arms and a mother. You will be very surprised at the different types of customers that we're going to have on the mountain. Our customers are not just those in skis. Our customers are anybody that is up at the mountain and up there, whether they're just looking and enjoying the beautiful mountain or they're there to ski. They're all going to be our customers, and we actually have seen them all. Advance the slide. So this is a basic preview or a cartoon of the anatomy and the physiology, and I think there was another chapter where you went into it probably in a little bit more depth, but when you look at the airway, you know, the airway begins at our lips and ends at our lungs, and then our airway is also divided and up to two parts. So you have an upper airway and then you have a lower airway. And you answered the question, the diaphragm is the major muscle in the chest. But surrounding the lung, the lining of the chest cavity is considered the pleural space. So our lungs are encased in this little pleural space and they have a little lining over it. Now, if you look where you see CO2 and O2, that's really where oxygen comes in and carbon dioxide goes out. So a diffusion occurs there, and that's where how all of the gases that we needed, oxygen and CO2, are exchanged in our bodies. And then, of course, it's delivered to the rest of our bodies through the blood. Next slide. Now, again, under the anatomy and physiology, you see where the diaphragm is. That is the major, most important muscle that helps us breathe. So I kind of, when you look at some of these charts in anatomy, always think about it when you're going to be treating a patient that maybe is on the hill, trauma, and how all of these various areas can be impacted by trauma. So then you show the neck. And then you show the shoulders, and you show the abdomen and the chest muscles. Those are called accessory muscles, and we'll talk a little bit more about that when we begin when we talk about a little bit of patient assessment. But those are all considered your chest accessories. So next slide, accessory muscles. And when a patient uses an accessory muscle to breathe, then you know you have I'm sorry, I shouldn't advance it too fast, but when you see a patient that's having to use their accessory muscles to breathe, and we'll see a picture that will actually show a patient, and I can show you what it looks like to see accessory muscles used. You know that when they're using those muscles, that patient is definitely in trouble, and you need to act quickly. Van, are you still there? I need a drink of water.
Yes.
Can you bring me some water, please? I'm sorry.
Yes, I absolutely will.
Okay.
No problem.
So we're going to look at some common respiratory emergencies. Now, the one that you're going to see and treat, oh, geez, all day, every day, will be altitude sickness. And I think in a later one, when you start talking about oxygen, you'll discuss it a little bit more. But obstruction and choking. Obstruction, again, the tongue is the major cause, the #1 cause of airway obstruction. Chronic obstructive pulmonary disease. Thank you. I need a drink of water. I need to just light up. Hold on. Chronic obstructive pulmonary disease. Now, oftentimes many people will go, if you have chronic obstructive pulmonary disease, emphysema, even asthma is part of that family. You go, what are they doing on the mountain? And older people come up so often, and they're just there to enjoy their family watching them ski. And most people are really clueless as to how their breathing and their oxygen requirements change in altitude. Oftentimes, we'll see the elderly patient or patient that has known lung disease come in with difficulty breathing, and they didn't even think about the fact that they were in altitude. Asthma, we see a fair amount. Cold affects asthma. Patients with asthma oftentimes will come up to the mountain, and putting cold weather on top of exertion, oftentimes these patients will begin to have trouble with their asthma. Hyperventilation syndrome, we've actually seen that patients, there's a lot of reasons that patients will breathe or have hyperventilation. Maybe they're excited, maybe somebody got injured and they start to hyperventilate. So we'll talk about that just briefly. And then pulmonary embolus, thank God I've never seen one on the mountain, but it certainly could happen, and you need to be aware of that. And do you know what a pulmonary embolus is?
That's when an embolus gets stuck in the arteries going to the lungs?
Yeah, if something breaks loose, it could be a clot. It could be a foreign body, somehow got in the system, and it goes in and it blocks one of the major airways. It can result in death, but it also can result in severe pain and dyspnea. You know what dyspnea is?
Isn't that labored breathing?
Labored breathing, difficulty breathing, yeah. And then the next one you might see as a result of trauma could be a spontaneous pneumothorax. I think we've seen a couple of those on the mountain, and that's when air gets in the pleural space, and what happens, it causes one of the lungs to collapse. And there could be a lot of other respiratory-related conditions as well. Go ahead and advance the slide. Okay, now I like this slide a lot because it's very visually impactful. We talked about how are you going to assess a patient when you're going to look at a patient. I think when you come upon a patient whether they're in the patrol room or you come upon a patient that's on the mountain, these are some things that you need to look for, because they're all going to be indicative of a patient that is in or headed towards respiratory distress. Our body's very smart. Once it realizes that it's not getting enough oxygen, then it begins a great compensation attack in terms of trying to help the body get the oxygen. So I think what you're going to look at here, we could see an altered levels of awareness when the patients get in altitude and they get a little altitude sickness, their oxygen levels begin low. If you've never experienced it, you might yourself if you don't go up there often and you don't ski, but you may have already been acclimated living in Alamogordo. But even just moving from Alamogordo up to the mountain, they'll feel dizzy, they'll feel agitated, they'll get a little restless, and we've seen it when it gets really bad. Cyanosis, cyanosis is the lack of oxygen. Their color will change on their face. And then if you look at where it says straining the neck and facial muscles, tightness in the chest in some patients, but if you look at the neck, if you see how this gentleman is sitting, he's sitting in a tripod position, and patients will assume that, and that will be your first indicator you may have a patient in respiratory distress, because again, he will naturally try to begin to compensate. Get the lung cavities, the thoracic cavity opened up by raising those arms, expanding that chest naturally. And then if you see the neck muscles begin to move and he's using his abdominal muscles, those are all accessory muscles. He may begin to like purse lip breathing, and that's when they just kind of like pucker and breathe air through a little space in their mouth. You may hear some coughing, some crowing. In a normal patient that's breathing, there really should not be any noise whatsoever. So when you hear a patient that's having noise in this breathing, then again you have to think, okay, this patient is having some respiratory issues going on, and they'll usually be able to tell you that as well. So when you look at a patient like this, what are some of the things you want to look at in terms of respiration?
Want to see what the respiration rate is, like how many.
Exactly. You want to look at the rate, and the rate changes with age. Don't forget, infants anywhere from 20 to they breathe fast, 20 to 25. Test questions here. Child anywhere from 15 to 20, and adult should be anywhere from 12 to 20. But again, keep it in, and you can see how the respiratory rate begins to change with age. Now, the second important factor in assessing the respirations of the patient is to look at the quality. And like I said, if the patient has normal, if he's breathing normally, we really should not be hearing him breathe. Now, I bet we've all had people we know with asthma, you may even have it yourself, where you can hear somebody wheezing. You hear that wheezing sound. If he's breathing normally, there's not going to be any real sound to it. And then his chest should be able to rise equally. So, like if you looked at his chest, you would want to look at that and say, does one side seem to come up higher than the other, or does it seem to expand equally and at the same time? And then the rhythm. So in looking at and assessing a patient in respiratory, you want to look at the rate, the quality, and finally you want to look at the rhythm. His rhythm should be fairly equal, so the time between his breaths should be fairly equal. Does that make sense? Any questions there?
That makes sense.
Okay. And a patient that's in respiratory distress will not be able to speak in a full sentence. So again, when you're coming up on your patient, let me use a drink. You're going to begin your assessment just by looking at him, and you're going to start talking to him. If a patient can't talk to you in a full sentence, like, do you get it? You know, any questions? Anything like, if he can't talk in a complete full sentence, and you have to think he's got some kind of respiratory issue going on is there. Anything, Jeff, I may have missed you think I should go over? Oh, he's muted. Okay, advance. Okay, now this is a pulse ox. And are you familiar with these? Have you ever had an opportunity to use them?
Yeah, I actually got one and started playing with it a little bit.
Okay, great, great. Now, I like to show this one, too, because we use them up there all the time, and most of it's probably on ours, just because it's a whole lot easier on a really busy day to have your own. And I like to say that this is a really invaluable tool to determine your patient's SpO2 levels, or his oxygen levels, okay? So there we see 97 SpO2. So we probably, so I think the book says, you know, it has to be 95 or above. And then there's this pulse rate of 72. And I always like to say, don't treat a patient based on this pulse ox. It is a tool that helps you finalize your assessment. Again, you're going to look at your patient and you're going, just like that picture of the man in the previous slide, you're going to make your assessment based on a lot of factors, and this pulse ox is a tool. And you can get a pulse rate off of it, but if you get your pulse rate off of the pulse ox, you're really missing a lot of other it gives you a good baseline, but always take your, that's a different chapter, but always take your pulse by radial pulse or wherever you choose to do it or need to do it. But again, it's good that you already have a pulse ox because you're gonna use it. Okay, go ahead and advance that slide.
Does it seem pretty accurate in cold weather? I think the book mentioned that the cold weather makes it a little funny sometimes.
Thanks for bringing that up. Yeah, nail polish, you might have to find somewhere like an earlobe or some other location to put that pulse ox on. If the patient comes in and their hands are cold, you're going to need to warm it up if you can't find anywhere else to put the pulse ox on as well. Now, another tool that you're going to have is being able to assess the patient's lung sounds. And that can be very, Jeff, are you there? I lost the slides.
It sounded like somebody got kicked off. I wonder if it was Jeff.
You know, I don't know. Let me see.
Are you still on the attendee list?
Yeah, he's still on my attendee list.
Maybe you could just keep going verbally and see.
Yeah, okay. Well, the next slide was, and this is, we won't bring it up, but what I would recommend, the book talks about listening to the lung sounds, and it talks about patients that wheeze. That's something we probably all heard if we have asthma or have friends that have asthma. Crackles, you can hear raws. But what's most important, and you really must know, is to determine what is normal and abnormal. So you need to, and if you go onto YouTube, because this was a great YouTube video, if you go onto YouTube, there's some great videos there that help kind of take you through the assessment of the various lung sounds. And you can practice it, but again, to me, it's what's most important is you recognize if a patient's breath sounds or lung sounds are either normal or they're absent or they're unequal. I don't get too lost into trying to say, oh, this is rows or these are crackles. I just really think it's more important you learn the sound of what a normal breath sounds like. And there's like a go into video and go into YouTube videos. I don't know if Jeff's going to get back on. Go into the YouTube videos and look up and Google breath sounds or type in breath sounds, and there's lots of videos there that will show you the placement on, and the book is also very good too, and how to do an assessment of lung sounds. So, Van, did you think of anything else over respiratory emergencies?
No, I can't. I think you covered it pretty good.
You have any questions on that, Marissa? So when you're checking the breath sounds, are you just using your ear? Do you carry a stethoscope, or?
Yeah, you can carry your own stethoscope, and there's stethoscopes up there. Yeah, I'm sorry. I'm sorry. I should have said that. You're going to do it with a stethoscope. And there's stethoscopes up there, or you can purchase a stethoscope and do it and have your own stethoscope. Just be sure you label everything. So it's really it's learning where to place the stethoscope on the chest and the back, and it talks about the various the different lobes in our lungs, and when you do the placement of the stethoscope on the chest or the back, kind of like where you're hearing. But for me, there's one kind of like right under the armpit where you can really hear good breath sounds. And that's the place I usually go to first and just say, okay, am I hearing normal breath sounds in that patient? But I can promise you there'll be more than 1,000 people up there that will be by your side to help you with this as well. Any other questions? Anything else, Van, you think I may have overlooked? Jeff, are you there?
I am. I didn't realize it cut me off. Could you see or hear the video?
No, you could not. It's not up.
Oh, could you hear it before though, or see it?
It just, when you went off, my video went off. The slides went off.
Oh, really? Oh, I'm sorry.
Oh, that's okay.
Well, do you want me to describe it to you? I guess it didn't like displaying it. That's weird. Or
Well, I never got to the slide where I could open up the video.
Really?
My slides just went away completely.
Let me try one more time. I had it. Can you see my screen now?
Yes, I can see.
Yeah.
Yeah. Okay, there we go.
Okay. So let me see what happens.
Yeah, let's see what. I think you just got kicked off again.
Yep.
We had trouble with this before. Videos, I just have never had luck with videos. But again, that's where I say go to YouTube.
Yeah, I can go to YouTube later. That's fine.
Yeah, go to YouTube and look at your breast sounds there. Okay, well, there it is.
You can see it?
I can see it.
Yeah.
Okay, let me hit.
You just got kicked
That's
off
gone.
again. It's not going to do it. Jeff, is there anything else you think well, there's still some more slides to go.
It's fighting, YouTube fights with pre-conference call. Oh, can you hear me?
Yeah, I could hear you.
Yeah.
Okay. So every time I hit play, it cuts off the screen sharing. So I guess I think it is up in the OEC skills on the channel. There's different playlists, and one of them is OEC skills. So you should. I apologize, I can't play it for you online, but if you go there and check it out, then you should see it.
Yeah. And like I said, YouTube's got this one. I got off YouTube, and I thought it was particularly good as well.
Yeah, it was.
So management of a respiratory distress. First of all, you want to determine if the patient is choking. If you've not done your CPR, you'll talk about CPR, but you'll also talk about the Heimlich maneuver as well. And can they speak? Can they talk to you in full sentence? What is their level of consciousness? Are they alert? Are they oriented? Do they know where they are? Or can you see I call it that glazed over effect. You can kind of see that they're beginning to lose consciousness or in their eyes. You want to keep them sitting up in a high Fowler's or a semi-Fowler's, and if the patient's in a tripod position or they're then you know that they're going to be in respiratory distress. Now, oxygen, determine whether you need a mask or a cannula or a non-rebreather, and that you're going to learn a little bit about that in another chapter. And then in cannulas, what we use most often on the mountain. But there are times we'll use a mask, and there are times that we will use a non-rebreather. And you want to think about a pulmonary embolus. Now, if you've never seen anybody actually have a pulmonary embolus, it's painful for number one, and they will feel the pain in their chest, and they will have extreme difficulty in breathing. And again, you just keep these people's head elevated, high Fowler's. You're going to put high flow oxygen on them. And when you start your oxygen, you can go start them high, and you can lower the oxygen. And oxygen levels and flow rates are going to be a discussion that you're going to have within a different chapter, because a mask, a cannula, non-rebreather, their flow rates are all a little bit different. And that's something you'll have an opportunity to practice when you go up to the mountain. Next slide. So again, we're just going to summarize essentially on this next slide. And again, respiratory emergencies, mostly altitude, to be honest with you. We have asthma issues up there. We're not allowed to give patients inhalers. We can assist them with their inhalers. If it's a severe asthma attack, there are paramedics, EMTs, and actually do breathing treatments with drugs like albuterol, but we're not allowed to do that, but they can help with that. And respiratory emergencies really are without respiration, your heart's going to stop. Everything is going to stop. So you've learned the ABC. So it's all about airway, breathing, and circulation. Because without all three of those working in concert, then the body will just come to a screeching halt. Any questions, Marissa? Jeff, did I miss anything, or can you think of anything I should have gone over that I didn't?
No, I think you. Oh, go ahead.
For ALS, how far are they away from Ski Apache?
That's a good question. For when they have to call for ALS, it takes them about 45 minutes to get up to the first aid room. So that's a really important question, too, because when you think, if you find a patient you really feel is in severe respiratory distress, you need to think about calling early rather than late, because it will take 45 minutes for the ambulance to reach the mountain.
That's also why it's really important to get the right patient info, you know, what their problem is and that kind of stuff.
And we didn't talk about, sample.
Yeah, there's basic, a couple of basic ambulances with Lincoln County, and there's a couple advanced. And if they send the basic life support out, they might not have, be equipped to deal with something that we have. So, but they'll tell us. You know, they always say if you forget to specify what their issue is, they'll ask. So. Yeah,
and that's where assessment comes in. And like I said, it sounds a little frightening if you've never been in the medical field, but there's so many good people up there that will help you determine. But it's important to make that call or make that decision very early with that 45-minute window there. Okay, now I guess we'll go to chapter 14.
Sounds good.
Mute while I switch. Drop.
And actually, 14 is on that same slide deck.
This one? Oh, really?
Yeah.
Oh, so just keep going?
Yeah, just keep going. Duh.
Okay.
Just keep advancing my slides.
Where was it? I thought we were at the end. Let's get rid of YouTube. Oh, here it is, PowerPoint. Okay. There we go.
Yeah.
I'm going back on mute.
We're going to talk about allergies and anaphylaxis. And I always say I'm not going to get deep into the physiology of allergies and allergic reactions because it is very complicated. But understanding what an allergy is, an allergic reaction, the difference between an allergic reaction versus anaphylaxis, what an antigen is, hypersensitivity, 4 ways in which the antigens may enter the body, and possible sources. Okay, next slide. And then again, we'll talk a little bit. Go ahead to the next slide. It says you're going to demonstrate how to use an EpiPen, and you'll do that up on the mountain as well, but we'll show a picture if you're not familiar with them. So again, our immune system is there to protect our body from foreign substances and or antigens by developing our own antibodies, which antibodies are a protein that are designed to attack a foreign body that comes in our body. And our blood and many parts of our body play a very important role in the allergic reaction. Mast cells, our white blood cells, hormones, blood, thymus, spleen, every aspect of our body actually responds to an immune system. Okay, next slide. Antibody antigen reaction. Again, I don't think I'm going to go into all of that. You could read it again in the book in itself. But when you think about an allergy, you think about, you know, being out in the woods, which is an ONC instructor. You might camping out. There's a lot of plants-based animals, furs, pet dens. Everything can cause an allergy on some people. On some patients. And there's a plant up on the mountain which I always something nettle that we have seen patients, they'll scrape up against it when it's in bloom or out, and it causes a horrible, horrible reaction. So next slide. We won't spend a lot of time going over all that. Because you know what, do you have any questions on what an allergy is?
No.
No, okay. So obviously the culprits are the peanuts that we all hear about and shellfish. And in environmental irritants, pollens, molds, plants, chemical, latex. We have non-latex gloves on the mountain. Anything that you just never know what a patient's going to be allergic to. So in terms of respiratory illness, you also have to start thinking in terms of allergies. Is this an allergic reaction as well? Next slide. So again, just some frequent causes of allergies and anaphylaxis, medications, blood transfusions, which, you know, you don't think about it on the mountain, but blood transfusion and allergies actually tend to be late appearing. So next. And again, this is just reaction, patient having difficulty breathing, a baby with some type of reaction there on the skin, whether it came in contact, did the baby take medicine, and again, this is when you're good assessment and patient history skills. Next slide. Now, there's types of allergic reactions, mild, moderate, severe, so we're going to talk a little bit about mild allergic reactions. It usually results in some type of just skin changes, mostly on the face, in around the neck, maybe mucosa of the mouth, their nose. They might get a little congestion. I think we maybe have all experienced that at some point in our lives. A milder reaction can come on in minutes. It may take days or hours. And it usually will kind of dissipate and go away on its own over time. Next slide. And again, a mild allergic reaction, or any allergic reaction, to be honest with you, you need to know the difference between the types, the degree of allergic reactions, mild, moderate, or severe, because there will be a couple of test questions on it. But they all have share about same of the symptoms that you may see. Itching, which is pruritus. You may see a patient's skin begin to flush. They may urticaria. They may develop a rash of some type or a hive. It may be at the location, if it was a local irritant, then it may be at the location where it touched the skin. Watery, reddened eyes. If you have allergies, you recognize every symptom that's in this list right here. Oftentimes their heart rate may go up. They may have a little tingling in around the mouth. I don't know if you've ever eaten any food and all of a sudden you go, oh, my lips tingle. That is a very mild allergic reaction, and they may get really, really tired. Next slide. Now, a moderate, again, mild, moderate, severe. You have to think. I don't get caught up and go, oh, is this a mild, is this a moderate? Just think allergic reaction and the assessment and the management of an allergic reaction. But these are important questions on the test. Now, the same moderate reactions essentially are same of mild, but they may be a little bit more pronounced. The patient may have a little bit more difficulty, more increased respiratory rate. Oh, their stomach may hurt. And again, they can appear minutes, hours, days, or later. So again, that's when it is very important in your assessment, in your sample assessment, which I think you've probably gone over, and we'll bring it up a little bit later on, that you ask those sample questions, because those sample questions can lead you to making a determination whether or not this patient might possibly be having some type of allergic reaction. Because if they have any type of allergic reaction, mild or moderate, I think you really have to be concerned with, I need to be prepared if these symptoms, this allergic reaction progresses to something more severe. Next slide. And again, if it's a moderate allergic reaction, time will take care of it. It will begin to disappear. We're not allowed to give any type of medication at all. No Benadryl, nothing can we actually give to a patient on that. But again, you have to be able to be concerned, is it just going to develop or progress and to become a more severe reaction, and do I need to, what do I need to do to take care of this patient? Next slide. Now, on a moderate allergic or a severe allergic reaction, you're going to see a patient that will become high anxiety. They'll feel it. They'll exhibit symptoms of anxiety. They'll say, I have a tightness in my throat. They may begin to have difficulty swallowing or breathing. You may actually be able to hear wheezing just with your ears and without a stethoscope. So when you have a patient present like this, you know you'll have a moderate allergic reaction. Again, keeping in mind it could progress and become a more severe reaction. Go ahead, next slide. They may have persistent angioedema. Do you understand what angioedema is? Swelling around the mouth?
Okay, that makes sense.
Okay. Again, abdominal pain and cramping. Again, remember our spleen, a lot of different body organs come into play once the body begins to have an allergic reaction. So, and the allergic reaction can take place in internally as well as externally. Nausea, vomiting, and elevated vital signs. So again, in assessment, when you begin the patient assessment, any patient, you should be taking vital signs, because they will always serve as your baseline. So if you see a patient that comes in, you think they're having a mild reaction, always take your vital signs. You always need a good baseline to work off of. Next slide, just a picture. Okay, that's just a picture probably of an allergic reaction, mild. You can see right around his neck, it's red, it's flushed, it's probably swollen. Obviously, it's very, very itchy. So you can see there that this may be more than just a mild allergic reaction. So you'll just need to be alert and watch him and see if he doesn't progress. You want to, again, your history and your questions during your sample. He may be very aware of what he's allergic to. He may not have even been if he's exposed to it. So again, going back to sample, the acronym SAMPLE, will help you find a lot of answers. These patients, you need to get that information as quickly as possible. Next slide. Now, a severe allergic reaction, that is a massive inflammatory response. And every system we have pretty much is going to be involved in that. Our skin, our circulatory, our gastrointestinal systems cause of a massive release of antihistamine. And if it's a severe allergic reaction, you're going to know it. You're going to see it if you've never seen one before. It is almost immediate. And so immediate, I think, is a key word there. It's going to occur within minutes or seconds. So if you have a patient that says, man, I just ate a corn tortilla and all of a sudden I have these symptoms, and if you looked at the prior diagnosis or prior definitions of mild and moderate, it always stated it could occur within days, hours, but a severe allergic reaction will occur within seconds or minutes. And again, obviously, if it's not treated quickly, it can lead to anaphylactic shock and or death, because if you look up all the systems that are involved, when all of those circulatory systems involved, gastrointestinal systems, those systems will start responding and trying to attack that antigen, and therefore they can shut down and death can occur very quickly. I've only seen one of these in my entire life, not on the mountain, thank God. Any questions?
Nope.
Oh, shoot. Next slide. like I said, if it's a severe, you're going to see anxiety. And I mean, it will be, I think, they will be very anxious. And a lot of patients even will express verbally, I feel like I'm going to die. And if the patient tells you that, you have to show a lot of respect to that, because whether it's allergic reaction or otherwise, if they have this sense of impending doom, you listen to them. As the reaction begins to progress, you're going to see their level of responsiveness go down. They may not be able to answer your questions. That's why you have to respond and get information from these patients as quickly as possible, or if you have other family members there. Then it will evolve into severe respiratory distress because all their airway begins to get clogged up with mucus. It begins to swell, and you might hear the wheezing, and wheezing is an early one, but when you hear a little, it's called stridor. It's kind of a hoarse little in and out sound that you can hear. I don't know how to describe it, and I don't have a sound for it. But when you hear stridor, it's a deep, deep sound. That means your upper airway's beginning to close down. So again, normal breathing should not bring sounds out. It should be almost silent. Then around their face, the hives are going to come in. The hives will show, and they'll get severe angioedema. So again, what you're doing is you're shutting down the access to air and the distribution of the air within the circulatory system. And again, you're going to hear abnormal lung sounds. You probably are going to actually hear them with your ears, and when you place your stethoscope and check your lung sounds, then you're going to hear different sounds. And that's why I always say, don't get too caught up on crackles and rows. Know what's normal, what a normal lung or normal breath sounds like, and know what is abnormal. Because once you get abnormal, you know, once you understand that it's abnormal, I hear that it's abnormal, then you're going to then you will know what you need to do at that point. And the inability to swallow. Again, everything begins, because of the massive histamine release, everything begins to swell. So everything gets so swollen, it can't function. Next slide. Now again, on the tachycardia. You know what tachycardia is?
Yeah, abnormally high heart rate.
Right, a fast pulse. And you might have an abnormally high heart rate, but when you do your peripheral pulses, whether it's pedal pulse on your foot, radial pulse, all those pulses may actually be weak, because your body, once again, is going to pull all of its resources and make sure that it's feeding as much oxygen as they can to all the major organs within the abdominal cavity, your heart primarily. So again, hypotension, low blood pressure, and that's why I say you always get a good vital signs on your initial assessment, because you'll be able to track and follow and document low blood pressure as their blood pressure begins to fall. They'll get a little pale, pallor, and they will develop cyanosis, because once the oxygen levels in the blood get below 80%, the SpO2 gets below 80, you start kind of turning blue. So then you know you're really in trouble when you start seeing blue around the lips and the mouth. Next slide. So preventing allergic reactions, they call it the AAA approach. Test question there. Awareness. Is your patient aware of the allergies that they have and what the triggers are? Avoidance of contact, and a lot of times patients really can't avoid it. I had a friend who almost died because the onion ring that garnished her steak was cooked in the same grease as shrimp, and she almost died before she could get to the hospital. So they may not have expected. So that, again, it goes back to a good sample and obtaining a good history and action, and what to do if the allergic reaction occurs. If it's an allergic reaction and it's respiratory distress, then you really have to think about calling ALS, because to get a patient down that mountain in a car would probably be not a good idea. Any questions there? Jeff, am I missing anything? So assessment. You may have to move the patient before you can do the severity of the allergic reaction. Determines whether mild and moderate can occur within minutes or days, hours, days, etc. But a severe allergic reaction will happen within seconds or within minutes. So when you're assessing that patient, you baseline vitals, and determine whether or not if you're concerned with anaphylaxis beginning to occur, which is a severe allergic reaction, and you just want to observe your patient, look at their skin, look at their face, neck, eyes, back, rash, swelling. Observe your patient and see the changes that may be occurring. And again, part of the sample, I think you've probably studied the acronym of SAMPLE. The M for medications. Does this patient have an EpiPen? Does somebody with him carry his EpiPen, or does he carry his own EpiPen? Next one. And you want to keep the patient in a semi-Fowler's position or a high Fowler's. You know what those are? You're okay with understanding the different body positions? Yes. Okay. So again, A, B, C, and D, that is our assessment. It's initial management. It doesn't change from patient to patient. You want to try to identify the allergen. Maybe he was exposed to a plant, maybe it was a piece of food, maybe a new piece of clothing. Try to identify it if you can, and he may very well tell you. A lot of patients will know what they're allergic to. So if they're out on the mountain and they fell into the bushes and they all of a sudden have these hives and rashes, you want to get the patient out of that and get them, remove them from the allergen if possible. And again, monitor and check your vital signs frequently. They will tell you a lot about what your patient's body is doing. So you always start with a good baseline vitals. Now, if your patient has an allergic reaction in other patients, but if your patient has an allergic reaction, I would check them every 5 minutes. I think that's what the book tells you, is every 5 minutes, or more frequently, whatever makes you comfortable and you can actually do. So if signs of a severe anaphylaxis appears, you're going to think AB's airway, breathing, circulation, and you're going to get transport calls, because again, it's going to take 45 minutes for that ambulance to reach the top of that mountain. Maybe they got bit by a spider, and if you can, you remove the stinger. If you have tweezers, I think the next slide, Jeff, shows how you can use a credit card. Now, during the summer months, and if you're up there patrolling for the bicycle patrol, then or working the first aid room, being exposed to bees and other creatures that have little stingers is something to consider as well. All right, next slide. Now, epinephrine is a drug of choice, and it's not a drug that we can give, but we can assist the patient in giving, if they carry an EpiPen, we can assist the patient, but we can't take it upon ourselves to get an EpiPen and give them a shot of epinephrine. And all that does, it increases the bronchodilation, opens up the airways, and the vasoconstriction that occurs as a result of an allergic reaction to help relieve some of the difficulty or the dyspnea and the hypotension. So it will kind of give the heart a little jolt and increase the pumping ability of the heart and increase the blood and the circulation. Now, EpiPens come in many different ways, and you can look at some EpiPens when you get up on the mountain. Next slide. And you can see some if you've never seen one. And like I said, most patients, if they have severe allergies, they will carry an EpiPen. So again, it goes back to that sample in your assessment, asking what medications. Do they carry an EpiPen? And there's an example of an EpiPen right there. Next slide. Another example. Next slide. So if you do have a patient that has an EpiPen, you do want to help them make sure is that their EpiPen and they're not carrying their best friend's EpiPen. Is it their name on it? Is it their prescription? Is it dated correctly? Let me see. I think that's about all on the EpiPen there. So, chapter summary. Overreaction to a foreign substance. Next slide. People don't know that they have some allergies. I had a friend who had eaten corn tortillas their entire life, and one day she had corn tortilla for lunch, and again, almost died before they could get her to the hospital. Tongue swelling is an ominous sign of an allergic reaction. So if you have a patient with tongue swelling, tongue's #1 cause of airway obstruction, and anaphylaxis can be fatal unless rapidly treated. That's why we have to be very in tune so that we can get that ambulance and get support to that patient as quickly as possible. Obviously, peanuts and allergic reactions can be prevented if you use the AAA approach. Next slide. Okay, that again, just to review, that's a test question right there. So again, awareness, avoidance, and action. Know what to do. Next slide. I think we're going to the next chapter. Any questions over allergies and
No.
Okay, good. Okay. Did I miss anything? Now we're going to go to 15, cardiovascular. Oh, perfect. Try it again. It did this to me before.
Taking myself off of mute.
Okay.
Whoops. And actually, let me close PowerPoint.
I'm kind of behind here. Oh my gosh, okay. Okay, our next chapter is going to be on cardiovascular emergencies. And if we get the first slide, when we get the slides open. I don't know. Okay, which one are you trying? Go to the second set of slides there. You see 215? Try the second one.
I tried both.
Oh, really?
We could go. Well, I think that's the stock one.
Well, we can try to go through that one if you want to.
Do you want it? Well, let me try one more time.
I don't know. It did that to me when I tried to open it, and then I just did it again. And I don't know what's going on there.
Not gonna work. Well, let me try the original. It'd be a little boring, but
well, we'll shoot through it here.
Skills.
I can open it on my screen separately if you want to just tell me what slide you're on.
Oh, you know what? Let me give you control, and Becky can talk, and you can do it. That's weird. I wonder why I can't open it.
I don't know. That
I
would
didn't even
be
think
easy.
about giving you control.
Yeah, because I took a lot of the slides out.
I know, yeah.
Did I take too many out?
No, it's totally
Okay.
fine. I think it was really good. Make presenter. Okay. You should be the presenter now. Oh, you're going to get some background noise.
Okay.
It says download to be a presenter, so I guess I have to download something? So I'm
I'm not.
downloading this thing.
Are you on a computer or on a tablet?
Computer.
You shouldn't have to download. I think you just have to accept.
Somebody just got booted.
Somebody just left.
Oh, what? It was you. No, I meant. No, it says you're still on, Van.
the computer, she might have hung up on the phone.
Yeah, Marissa's phone is not showing up, so maybe that's it. I don't know.
It says becoming presenter.
I know.
I think you have to accept, and then you'll have to share your screen. Somebody's back.
This is Marissa. Yeah.
That's Marissa.
Oh, sorry, the call dropped. I don't know why.
Oh, that's funny.
Let's see. Start sharing. Yeah. Select all, I guess.
There we go. Oh, and we're seeing your. I think we're seeing your screen.
Okay. I see somebody there.
Oh, that's funky.
Yeah, that is.
Does it look weird?
Yeah, it's got some little. I don't know.
Oh yeah, open with Google Slides and. Wow.
I'll just open it separately.
Huh. Okay.
Okay, there we go.
Can you see it now?
Okay, next
Does that
slide.
look okay?
Yep.
Here we go. I'm going to go back on mute.
Okay. I like this slide, chapter in a nutshell. You're going to need to know the various cardiac conditions, signs, and symptoms. Now, assessment. Oh, I don't know if you've studied these yet, Marissa.
I don't remember it yet, but yeah.
Okay. Know them inside and out. That's very, very important, okay, because that's all going to be part of the assessment. And management, ABCDs. ABCDs you're going to hear over and over again. You're going to treat for shock. You're going to give high-flow oxygen. You're going to need rapid transport. Keeping in mind it takes 45 minutes by the ambulance to get up there with an ALS ambulance to get out and hand off to your EMS. We have an AED on the mountain. You will open it. You will get it ready and be prepared to use it and be prepared to give CPR. Thank God. Next slide. I'll try to get through these because we're... Okay. This is kind of a slide. I think it's important to have a very basic understanding of the anatomy and the physiology of the body in general, but as well as the cardiovascular system. We have three types of veins, arteries, capillaries, and veins. Test question for you there as well. And on here, the blue represents low oxygen and high CO2, and the red is high oxygen and low CO2. But if you look at the heart and the role that the lungs and the heart play in our whole system, I think that's what's important in the understanding. Go ahead, next slide. You're going to want to know the blood flow of the heart, where it comes in from the body and where it's sent back out to the body. And of course the heart has 4 chambers. You have a left side and a right side, and you have atriums, left atrium and right atrium. And that's important to know because, again, one represents blood supply from the body and one represents blood supply out of the body. And ventricles, atriums, all of your valves, I think it's very interesting. And you might have a patient say, yeah, I've had a valve replacement or I have a heart murmur. That's where that kind of all occurs right in there. And on the surface of the heart, within these muscles, is where the whole electrical system for your heart is located. And that's important to keep in mind for trauma that happens to the chest cavity. So I would know the flow from the lungs, the heart chambers, ventricles, and the flow from the body back out to the body. Any questions there? Next slide. Most causes, common causes of cardiovascular disease, we all know, we hear it on TV for every drug commercial, is the leading cause of death worldwide, and it can be caused by coronary artery disease or atherosclerosis of the heart's arteries, of the legs, are the most common areas. Next slide. I'm trying to hurry here. Now, hypertension is probably the most common thing that you've heard of and that you'll actually see. Hypertension is defined in the book by 140/90. Now, those guidelines have changed somewhat. I'm not really sure what it is, but that's a good right there. The systolic is 140/90, and elevation in altitude can cause the blood pressure to go up. And again, it's a compensatory mechanism because your heart realizes it's got to pump a little bit more and get it out to the body. And some hearts are weakened and they can't get out as much, and then they get out into altitude and their heart's unable to pump out adequate supplies. And hypertension leads to a host of damage to the body, kidneys, lungs, so much more. Then so many other stroke, kidney failure. So people that are not treated for hypertension are just asking for long-term health issues. But again, altitude will affect a patient's blood pressure. And we've seen it where patients on blood pressure medicine come in, their blood pressures go up high, and the only recommendation we can give them is you need to go down to a lower altitude. Next slide. Congestive heart failure. Remember we talked about the different, the atriums and the ventricles and the blood flow, where the blood comes into the lungs and where the blood goes out to the body. So what this slide is just showing you, the left side is it's pulmonary edema because the blood supply getting in is getting restricted or resistance in the lungs, so the fluid builds up in the lungs. So they'll get fluid in their lungs, and you'll be able to hear that. And then right-sided heart failure, the right side of the heart begins to get weak and fail, and you'll see edema in their feet. And that's really what you're seeing there. Next slide. Now, distinguishing angina from a myocardial. Do you know what angina is?
I forget.
Okay, it's kind of like a heart pain. It's when the heart supply of oxygen becomes inadequate. The muscles begin to suffer damage, and they'll feel some pain. And a lot of patients have angina, and they'll take nitroglycerin tablets for it. So I don't know if Jeff would agree or disagree. I don't think we have to get too caught up other than for testing, distinguishing angina from myocardial infarction. Or myocardial infarction is actually when you have a heart attack.
I'd agree. You need to know it for the test, and then after that, you just need on the hill. It's heart problem, O2 and transport.
O2 and transport. So you can I won't go over all of those. So again, I don't think you should get caught up in trying. We're not there to diagnose, but we need to have a mild understanding of what could be. Next slide. Sudden cardiac arrest. I've never seen it, thank God. But at this slide, it shows you the chances of survival from a cardiac arrest. And it's happened on the mountain. So knowing where your AED is and being able to administer defibrillation, you can see how important it is to identify a cardiac arrest when the heart stops, and the amount of survival time, how it goes down with each minute that is delayed. Because with each delay in definitive treatment, oxygen and CPR, whatever, defibrillation, damage to the heart muscle occurs. Next slide. Sudden cardiac arrest can occur without warning. They will just literally drop right in front of you. I've seen it. And they will literally just drop down on their and fall right there in front of it. There's a lot of causes to it. Patients may have pre-existing condition that has predisposed them to it, but also cardiac arrest can occur as a result of trauma, which we'll see on the mountain. Asystole, that is no heart contraction at all, and that's fatal. Next slide. A thromboembolism, we talked about that. It could be a blood clot that travels to the heart, the brain, or the lung, and it could be caused by deep vein DVTs. You need, again, it goes back to assessment, getting the medical history, prior medical illnesses, if they have a history of DVTs, and a pulmonary embolism is the most caused, but because you can't breathe. But in a heart, if the clot goes to the arteries and veins in the heart, or arteries in the heart, then it kills the heart muscle because it blocks the supply of oxygen to that specific area of the heart. Next. Pericarditis, the heart is actually enclosed in a sac, and pericarditis is an inflammation of the sac around the heart, and there's lots of causes. It could be a heart, drug users, injections, people are shooting up drugs, causes a lot of pericarditis. Pericardial tamponade, I think, is kind of important to keep in the recesses of your brain, because that is something that could happen with blunt force trauma to the heart. And it's like you just hit the heart, and the muscle in the heart begins to react by swelling. Fluid is released, and it fills up that sac surrounding the heart, and therefore restricts the heart's ability to contract and work functionally, and that's life-threatening, and it's nothing we can do about it. But when you have a patient that has received blunt force trauma to the sternum, to the front chest, that is something you always have to keep in the back of your mind. Next slide. An aortic aneurysm, there may be symptoms, there may not be. The only symptom may be is they literally have severe abdominal or severe pain that moves up their back, and it's a rupture of the major aorta in our body, and it's nothing we can do about it. It's lethal. There's no stopping it. If it ruptures, that patient will not make it. Next slide. Aortic aneurysm dissection, I won't spend a lot of time on that, but always keep in mind that as we age, most of us will develop some type of aortic aneurysm. So older people, if all of a sudden they complain of severe abdominal pain or stabbing pain that moves up and down, that moves up the back, you can, in the back spinal area, you can think of an aortic aneurysm. But again, there's nothing we can do about it. They have to go to the hospital. Next slide. That just shows the aortic aneurysm. Before it ruptures, you may be able to feel it when you're doing abdominal palpitations. We'll talk about it later. But if you're palpating the abdomen, all of a sudden you feel this like, oh, what is that mass in the abdomen? All of a sudden it feels like it has its own little pulse going. You can think of the possibility of an aneurysm there. And again, there's not much we can do about it. Next slide. Chain of survival in the management. Test question here. Chain of survival. And again, for cardiac emergencies, immediate recognition of a cardiac arrest and activation of EMS. Call ALS. Get the ambulance on the way. High quality. You're going to have your defibrillator available and ready. And again, it's important to get the patient down, because the longer you wait, the more damage to the heart's going to occur. Next slide. Other things you're going to find patients that may have implantable devices. Some of them may be pacemakers. Some of them could be pacemakers that actually have a defibrillator on them, that when It automatically will detect when it needs to shock the heart in itself. I've run across a couple of those patients as well. And you can hear the difference in heart rate when a patient has a pacemaker in. Patient may carry their nitroglycerin. You need to ask them if they have it. If it's their prescription with them, you will follow the protocols and you allow the patient to give it, to help assist them in giving their nitroglycerin. And oh my gosh, I just forgot. You can give the nitroglycerin, the first one, and then you have to wait 10 minutes, I think, before you give the second one. But they'll know how to give it. Just make sure that they have it. And aspirin, if they have any aspirin, I would suggest they have an aspirin. And I don't think we're not allowed to give aspirin. But if the families do, they can give it, but we can't. Because aspirin helps decrease the blood clotting and blood clots that can occur when the heart's not beating normally in its normal rhythm and pushing that blood through. That's when blood clots begin to form. Next one. So assessment, I think you've done patient assessment. It's always seen safety, ABCDs, oxygen, sample, whether you get it from the patient or whether you get it from the family members, OPQRST acronym, and you're going to monitor vital signs frequently. Get that initial assessment and get those initial vital signs. It's critical to being able to take care of that patient. Next.
That's the end of the slideshow.
Okay, Jeff, any questions on cardiac? Anything I forgot, Jeff, or needed to go over a little bit more thoroughly? We breezed through that one.
I think that covers it. The only thing I would add is, that for the practical, a lot of it you're not going to need. It's just recognize there's a cardiac emergency and get them off the hill. For the written test, yeah, you read the chapter. They love pericardial tamponade, and so I would bump up on that question especially.
Yeah, because that's always when you see trauma. Chapter 16, GI emergencies. Okay, I don't know if this is this my slide deck, Jeff?
What?
Oh, okay. Are your slides up, or is Jeff opening my slide deck?
No, that's.
I didn't open it.
Yeah.
You what?
I opened it.
You opened it. Okay. Well, I'll try to see where I am. Okay. Next slide. I always again. Read your objectives, look at your objectives, because embedded in there are your test questions as well as your test bank questions, okay? You want to know the 6 possible causes of emergency, signs and symptoms, and contrast visceral pain and parietal pain. Next slide. We're going to talk about how to assess the abdomen and what to do with a patient with severe GI emergency. Next slide. Those are our topics. Next slide. Keeping in mind that in our abdomen and our pelvis we have hollow organs and we have solid organs. And that's kind of important to know, because if you have hollow organs, that means they're hollow because they contain something, like your stomach, gallbladders, large intestines, your bladder. So in trauma, knowing where these organs are located and what possible organ could be injured, because if it's a hollow organ, then it's going to release something into the abdominal cavity. And then if it's a solid organ, like a liver, pancreas, spleen, and ovaries and so forth, your pancreas can release, if it's damaged, it can release enzymes into the gut that can hurt. So it's just understanding the various organs that are in the pelvis. Next slide. And again, this is just a slide on referred pain and references, because the abdomen, in acute GI or gastrointestinal emergencies, when you're assessing the abdomen, you don't need to make a diagnosis. It's what is causing it. Is it the bladder? Is it the gallbladder? Or where it could be coming from, because a lot of the abdominal pain can be referred. This is what this one is showing. Stomach pain can present between the shoulder blades, spleen up around your shoulder. So again, it's just talking about what referred pain is and how deceiving an abdominal injury can be. So again, it's just understanding that you're not there to diagnose what got injured, but you're to diagnose, be able to quickly identify a potential life-threatening injury and what's in that abdomen and what can be injured and hurt. Okay. You can't always pinpoint what's going on in an injury in the abdomen. Sometimes a patient can actually right lower quadrant pain. Probably everybody on this earth knows, oh, I have pain in my right side. Well, we automatically think of the appendix. And it's a hollow organ, so if it ruptures, what happens? All of that content of the appendix is spilled out into the abdominal cavity and it causes peritonitis. So that was an easy one to pinpoint, but the severity of the pain does depend upon the structure. And you can have visceral pain, and in visceral pain, the visceral nerves, the gut nerves are irritated, and the pain can be like patients may grab, I hurt all over. They can't pinpoint it. And then you have sensory nerve pain, parietal pain. That's when a patient, example, again, the appendix, it can point to his right where that pain is coming from. But again, the pain may be distant to where the actual injury is. And that's what this slide is telling us there. Again, we're to be able to, next slide. These are causes of the acute abdomen. Now, acute abdomen is a medical term. And it's kind of an ambiguous term because what I'm trying to say is you cannot pinpoint just by a physical assessment where the actual damage might be done, whether it's appendix, liver, hepatitis, liver infection, cholecystitis, that's gallbladder infection, pyelonephritis, kidney infection, and nephrolysis, that's kidney stones. So kidney stones can be severe, it can be painful, it can move around. So that's why it's important to be able to just recognize that you have something acutely happening in the abdomen and the various organs that could be involved in it. Next slide. Causes, again, it could be a bowel obstruction, they could have perforated their bowel. When they fell on the mountain and they think they're not hurt, but their stomach's hurt, their stomach is tender and painful, they could have perforated their bowel. They could have peptic ulcer disease, esophagitis, gastrointestinal bleeding. Again, OB-GYN-related conditions. Again, I go back to a story that Jeff told. He had a patient on the mountain that was having abdominal pain, and he was smart enough to ask her when her last period was, and come to find out, sure enough, her abdominal pain was caused by an ectopic pregnancy. So Jeff was very good in his questioning and his sample, and again, couldn't pinpoint the pain and say, oh, she's got a pregnancy in her tube. That's what an ectopic pregnancy, in her fallopian tubes. But it was just abdominal pain. But Jeff did a good assessment, asked the right questions, and found out that she had missed a period, and his thought was she could have an ectopic pregnancy. Next slide. Other causes, gastroenteritis, my goodness, we see that a lot. And if you think these patients are sick, they've come in, had a little diarrhea, a little vomiting, a little nausea, but I came onto the mountain earlier, get them out of the first aid room. You're going to use precautions, and you're going to get those patients out of our first aid room and down the mountain as quickly as you can so we don't share it. And we'll talk about personal protection later. Indigestion, colic, diarrhea. I think we've all experienced probably most of those. Next slide. Other causes, viruses, protozoa, bacteria, and you're asking, why are we talking about this on the ski mountain? But if you're up again in the summer, Giardia is something you get from contaminated water. It's I think it's a protozoa of some type. E. coli from contaminated water, feces, constipation, cystitis is a bladder infection. Last year we had a young man who had a known history of constipation, and he had severe abdominal pain. And he actually, parents came in, he was, I don't know if you were there, Zeph, but he says, well, he has a history of severe. He actually went to the bathroom and felt better. So constipation in a lot of patients can cause severe abdominal and low back pain as well. Any questions, Marissa?
Nope.
Nausea and vomiting, get them out of the mountain. Get them out. Next slide. Get them out of the first aid room. Again, everything boils down to a good assessment on your part. You're going to think ABCDs. You're going to do your sample. If they're having abdominal pain, you're going to do the OPQRST. And if you know these acronyms and you use them within your assessment, you will serve your patient and yourself very, very well. An abdominal exam, we're always going to ask permission to touch our patient, but in an abdominal palpitation, you're going to touch them probably in some areas that they may not understand. Next slide. And this is just a quick view. It's from your book, how we divide the abdomen up, and it starts the center point, these two perpendicular lines. The center point is your belly button, your umbilicus. So we know in our left upper quadrant, we can think about these are the organs, liver, kidney, spleen, that we're going to find in the left upper quadrant. So look at this slide, and I think it's a good slide to know. Again, it falls in understanding your anatomy, where things are located, because in trauma, you want to think about if they have severe pain or they injured their left upper quadrant, what could they have hurt? Any questions on this slide?
No.
Okay, next slide. Okay, there's a parietal pain right here. He can pinpoint to you exactly where he's actually hurting. Next slide. Other patients, or just say, I hurt all over. Now, this slide you're going to begin, this is going to show you the method for abdominal palpitation. You'll get a chance to practice that. You're always going to wear gloves. But see the placement of her hand and her fingers. You don't put your whole hand on their body. You just kind of overlap your fingers. And don't be afraid to press. Don't be gentle. You're not going to hurt them or cause any more damage by pressing. But if you press good enough and deep enough, you'll be able to feel. You might be able to pinpoint maybe some abnormality within that. Thinking again of all the organs that are in each quadrant. Now, if the patient has pain, you don't want to start your assessment right where the pain starts. You want to go to the opposite side, the opposite quadrant, and begin your assessment there. And be very systematic. Just move around it kind of like a clock, clockwise or counterclockwise, whichever works for you. But go, just mentally divide that abdomen up using your belly button as your center and divide it up into 4 quadrants. And you're going to end that physical assessment right above your pubic bone, because that's where your bladder is going to be. So move it around and then end it right above your pubic bone and see if you feel anything abnormal in there or well. Next slide. Okay, in-depth physical examination. Again, this is, I think the whole theme here is ABCDs and a good assessment. You're going to put them in a position of comfort, and oftentimes patients, if you've had a belly ache, you want to sleep on your side, or you want to get your knees bent up and take some of the stretch and pull of the abdomen off of them. But again, vital signs frequently. If you have a patient that has internal damage in the abdomen, let's say he's got a ruptured a blood vessel or ruptured an organ, your vital signs are going to change. So again, always take those vital signs and take them frequently. Every 5 minutes or as frequently as even more frequently if that you feel that that's needed. Supplemental oxygen if needed. I personally give oxygen to everybody that comes in, to be quite honestly. And Jeff, you may disagree. That's why I say use your pulse ox, but don't always let that be your, that says, yeah, use it, don't use it. Oxygen has been shown to help relieve pain because it takes some of the irritation off the nerve endings. So low flow oxygen in many of these patients is not going to hurt them, and I think by far it may actually help them. But key point here, don't ever give them anything, no water, no anything. Don't let the family come in and say, here, take a drink of this. You keep them what they call NPO, nothing, that's a Latin term, nothing per os, I think it is. Because if they have an acute abdomen, they may require surgery. And by allowing them to eat or drink, then it's going to delay their surgery. Next slide. We won't go over that. Be prepared to recognize the patient has an acute abdomen. Don't worry about trying to diagnose what's going on in the abdomen. Recognize that you have a severe problem, acute abdomen. Again, understand your anatomy in the abdomen, in the pelvic area. Next slide. And I like this cartoon. Now I told you about the food. Would you like to see pictures of the resort we stayed at? That would be nice, but I think I have enough information to see we need to get to a hospital. And the answer is right there. We need to get to a hospital. Don't get lost in diagnoses. Okay, that's it. That finishes it for me, Jeff.
I'm good. Nothing to add?
Van's up next. Oh my God. I went too far over. Okay.
Do you want me to try to flip control to you?
Yeah, if you could.
Yeah.
That would be great.
Okay. Let's see. I think I can do this. Make presenter.
Hey, sweet girl. Y'all okay out here? Y'all need anything?
Oh, let me go tell my mom she's still.
Yeah, I'm still on. I'm sorry.
Okay, we can hear you.
Okay, I'm gonna hang up.
Okay, download. I had to download too. Let me try that.
Okay.
Let's see.
I think I'm still seeing Marissa's screen.
I think so too, yeah. Can she possibly make me?
Well,
What?
I made you presenter, but I think it's waiting until you accept.
Yeah, I mean, it says then is becoming presenter, apparently.
Okay.
So.
Yeah. Oops, let me try again.
Okay.
Okay. Let's hope that works.
I have chapter 25 pulled up, so let me know if by chance you guys can, if and when you see it. Share your screen, okay. I don't know why it's telling that. Okay, here we go. Let me try this again. I'm going to run it.
Okay.
Hang on. All right, one more time.
Garage door.
That's me.
Okay. Okay, let's see. Open, let's see. Let me see if this is going to work. By the front door. Okay, let me see. I don't know what's going on. I've got an hourglass, so just hang on 1 second.
Okay. I'm going to go on mute.
Where's that money you sent me today?
Okay, hold on. I don't know why it's running, but hang on. Let me see if it's going to do anything. Okay, I'm not sure. Okay, hang on. Nope, it's working. Hang on. Okay, I'm on the telephone. Already done that. Need that. Okay, if you'd agree, please select the monitor. All right. You know what? I'll just share my desktop.
Almost there.
I think so. Hang on. Okay, can you see my desktop?
Yes. Now we can.
Okay.
All right, I'm going on mute.
Perfect. Perfect. Make sure. Okay, there we go. Okay, so I have 5 chapters. I'm going to breeze through. Let me know when you have questions. I'm going to point out some of the things that I think are relevant to what we do on a daily basis up at Ski Apache and throw in any little pieces of information, again, that would be unique to the ski area. But what I can say about all these chapters, as I'm sure everyone else has told you, study the whole thing, study your test bank questions, and you should be absolutely fine. Okay, so chapter 25 is cold-related emergencies. So we're going to look at, see if I can, assessment, management, evacuation, and transport. We're going to skip over the case disposition and kind of the summary, just in the interest of time. So when you look at how we lose heat, there are 4 different ways that we lose heat from our body: convection, radiation, evaporation, and conduction. I won't bore you with the definitions, but they are test questions and definitely things that you need to know, because obviously we work in the ski area in a cold environment. So these are things that we will definitely see as we're working in the first aid room and out on the mountain. So make sure that you know the 4 mechanisms of heat loss and their definition. So obviously freezing temperatures, just being cold outside, is something that can contribute to a cold injury, but also high winds and high altitudes, which we have both of frequently. Well, obviously Ski Apache is at a high altitude already, and we oftentimes have high winds. So those are things that we'll encounter on a regular basis while we're patrolling. Use of drugs is also very common to see. People are on vacation and they're having a good time, so we'll see lots of alcohol and recreational drugs over the course of the days that we work. So previous frostbite injury, if you've had frostbite before, you're definitely more susceptible to having it again. And then overexertion, which if people are skiing, they're working hard. So these are all things that contribute to a cold injury, and we experience and see all of them when it's snowing. And here's something that we definitely know. So in New Mexico, you'll appreciate this, or Jeff, is that we get a lot of Texans coming to ski, and many of them are doing it for the first time. So they don't often bring adequate clothing. It doesn't always fit. They may have borrowed it from someone or rented it at a rental shop. So we run into all types of situations where people just are not adequately covered up. We see people come in all the time without gloves. They fall a lot when they're first learning to ski, so they get wet and cold. Dehydration is also a big problem, not because we're at altitude, and we're going to talk about altitude later on. People need to drink almost twice as much water as they would normally drink, and they don't often do it. So dehydration can be a big problem. Impaired circulation in some way.
Okay.
Oh, sorry. Hang on one second. Impaired circulation, whether from an injury or illness, and then of course poor nutrition. I can't tell you how many times we talk to people who didn't eat breakfast or at 3 o'clock haven't had lunch. So these are all things that you'll see frequently at Ski Apache. So understanding the different types of cold emergencies, the difference between frostnip and frostbite. Frostnip is superficial and there's no damage. Hands are going to be cold. They may be a little red. They may tingle when they start to warm up. But ultimately, frostnip is superficial and has no permanent or long-lasting damage, as opposed to frostbite, which is actually the tissues of the body freezing. And it can be partial thickness and full thickness. I've never actually seen frostbite live, but we see frostnip quite frequently, especially in young children. Another big cold emergency is hypothermia, and that's primary hypothermia is due to environmental exposure. So again, being outside with ill-fitting clothing or being outside and getting caught outside for too long or getting wet while you're outside can all cause primary hypothermia. And then, of course, secondary hypothermia due to other systemic disorders. Afterdrop is when the body temperature continues to drop even after you have started the warming process. It's definitely a test question and can actually be a life-threatening situation. So something that we probably wouldn't see it too often in the first aid room. It usually happens after transport to a medical facility. And then, of course, windburn, which is essentially irritation to the skin. We've probably all had it. It looks like a sunburn, but it's the actual burning of the skin from the wind. It's actually the cold wind. So this is I just thought it was a sad and a funny picture. But again, at Ski Apache, people are on vacation and having a lot of fun. Alcohol can definitely be a big influence on incidents that we see on the mountain. This was just another example of she's sitting out in the middle of the snow with no gloves on. And again, we see people all the time skiing down without gloves, hands just so cold and freezing. So one of the most important things to remember when you encounter hypothermia or frostnip or frostbite on the mountain is to not become the victim. Although it may be tempting, don't ever give up your jacket, because we don't want you to be next. And then be prepared. You have to know your environment, know where you are, know how far you are from the aid room, and know how you can get that person transported to the aid room in the quickest fashion. And you, as a patroller, should always bring adequate clothing. So I know most of us bring several layers because you never really know what the day is going to end up like. You could be hot in the morning and freezing in the afternoon. So always wear layers. And make sure that they're the wicking layers that can wick water away from your body.
I carry a pair of really cheap, like $2 gloves, because you never get your gloves back if you give them away.
It's a really good point.
Dollar store.
Give away the cheap ones.
Oh, yeah. And you see so many people skiing without gloves that I just carry them now.
I'm constantly amazed how many people I see skiing without gloves. It will blow your mind, but it happens literally every time I'm up there. So the best way to prevent cold emergencies are to be attentive, not only to the people that you're with, but to yourself. Again, make sure that you're eating and make sure that you're drinking all day long, and stay dry. Some of the other recommendations around preparedness: avoid clothing that's too tight or restrictive, boots that are too tight that are going to make your feet, end up with poor circulation and more susceptible to a cold-related injury. And then change your socks. Never wear or start the day with wet socks. That will not be good. And as much as possible, we advise people on the mountain to avoid alcohol. I can't advise against caffeine because I need it to function on a daily basis. But alcohol and recreational drugs, if at all possible, when on the mountain, it's too much of a danger to not only themselves but to other people around them. And if you ever have numbness in feet or hands, or a patient tells you that, they should come out of the elements immediately. So again, when you're looking at assessments, all of your scene safety, again referencing, don't become the victim. Don't give up your jacket and don't give up your gloves. Make sure that you as a rescuer can be there and be safe for the patient that you're taking care of. And like any other scene that you happen upon, you start with the ABCs assessment, which I know you've probably heard and will continue to hear ad nauseum for the remainder of your training. And then look for the signs of cold injury. Look for people that may have been sitting there and taken their gloves off or started out with no gloves. Look for signs of shivering, which is often the first sign of early hypothermia. That's the body's first attempt to rewarm itself. So look for the signs when you come upon a scene. And this is just a picture, I thought a really good picture that we had in the slides about what frostbite could look like. And this is, again, it's a very serious injury that can result in amputation, tissue death, gangrene. Not a good situation. So again, remember your acronyms, as Becky said earlier. DCAP, BTLS, and SAMPLE are important to make sure that you're getting an adequate history and understanding completely the situation, and of course measuring core body temperature. So how can you manage it? So with frostnip, get inside, out of the cold, into a shelter. In our case, it would be get them into the first aid room, or once they've warmed up, with either warm bottles or blankets in our first aid room, to stay in the lodge, get to the car, or head home. And then frostbite requires that you warm the area rapidly. So you have to consider different factors, and with frostbite as opposed to frostnip, like when to warm it, you need to make sure that you can warm it in an environment where it's not going to refreeze. And then where. So it's very specific. You want to submerge it in water and keep it off the side of whatever is holding the water. And again, you need to be undercover in an area that you can do that safely, and there's no risk of refreezing or exposure. And then again, how? We use warm water submersion to warm the part that's frostbitten. And again, there's a lot more detail that goes around this in your book. So just make sure that you stay up on top of that. Here's an example of what warming might look like. Although ideally they wouldn't be stepping in the bucket. If they couldn't hold it themselves, you'd be helping them hold it in the center of the water. And you keep the water moving so that the temperature of the water is consistent around, and you can add warm water as necessary. With excuse me. With hypothermia, the primary goal in management is to prevent further heat loss. So shivering, again, is a passive warming method. The body is going to do that on its own, all by itself, and that's a good thing because shivering is going to help them warm up. So once they're in the aid room, they're shivering, we can actively help them warm up by using a heat source. And in our first aid room, we use warm blankets. We have a dryer. We'll throw them in there. We have water bottles, hot water bottles that we can heat up in the microwave and put them either let them hold them or put them under their armpits or in their groin area to help them warm up.
We have a cooker too. There's a bag with like a giant hair dryer, and you put the person inside the bag.
Ah, that's true. That's true. I've never had occasion to use it, but I forgot about that. And then for patients that don't respond to warming, immediate transport as soon as you possibly can. Again, for us, that's a minimum of 45 minutes. So they need to be gone as soon as possible. And then never rub the skin of a patient with frostbite or frostbite so that you don't cause any further damage. And as usual with any patient that's in a potentially life-threatening situation, monitor their vital signs on a regular basis. Okay, that's the end of cold-related emergencies. Any other questions about that? Any questions at all?
Nope.
Okay. We're going to move on to heat. Oops, sorry. Let's see if it'll go. Heat-related emergencies, which we don't often see in the dead of winter unless somebody gets a little overexerted. It can be really warm in the springtime. So if somebody is skiing really hard in the springtime, you may see it. But we also do operate the mountain year-round and get some decently high temperatures. I live in Austin, so it's hard to say that anything's hot outside of here, but we do get some high temperatures up there during the mountain biking season. So we're going to go through a little bit of anatomy and physiology, talk about some of those related heat-related emergencies, how to prevent them, talk about lightning, and then we're going to skip over the assessment management. I'm sorry, we're going to talk about assessment and management, but skip the chapter summary. So again, mechanisms of heat loss. I think we covered this to some degree in the last chapter, but how our body regulates our body temperature, and it does it in 4 different ways. Again, convection, radiation, evaporation, and conduction. So make sure you understand the difference between the 4 and are familiar with their definitions. So there are 2 basic types of heat emergencies that heat-related emergencies that we're going to talk about. We're going to talk about heat exhaustion, and we're going to talk about heat stroke. So signs and symptoms can be similar, but one can be very life-threatening, and the other one is usually a minor emergency, and patients can recover pretty quickly. There are also different types of heat-related emergencies. Syncope or fainting could be due to a cardiovascular cause. It could be just temporary. And then, of course, you've got muscle cramps, and they can happen feet, legs, any muscle in your body. It's usually due to electrolyte issue imbalance or primarily due to dehydration. Oh, there we go. I'm trying to move that thing. Okay. Now my slide. There we go. So again, heat exhaustion and heat stroke can have very similar symptoms, but also some several things that are very different about them. So person can feel weak and exhausted. There may be nausea or vomiting and skin that is either normal to cool in temperature or could be hot and dry. So in cases of heat exhaustion, you're probably still sweating. You've gotten too hot. Your body temperature is below 104 degrees. You may be dizzy and weak and short of breath, but once you're removed from exposure to heat and hydrated, then you should return to normal. In heat stroke, however, you can experience all of those symptoms. However, extreme responses, your body actually stops sweating. So if you find a patient that's hot and dry, their skin is dry, that could be an indication that they're progressing to heat stroke. In most cases, the patient's body temperature is above 104 degrees, which can result in seizures, altered mental status, and could result in permanent damage if not treated. So how can you prevent it? Really, much like being in a cold environment, you need to be prepared, you need to be hydrated, and you need to be prepared. You need to wear the right clothes in the heat, and you need to make sure that you're drinking lots and lots of water. Heat acclimatization is also important. So if I'm going to go to Egypt and run a 50-mile race, I actually know somebody that did that, and I thought he was nuts, but I'm not going to show up in Egypt and having only run 50 miles in Rio de Janeiro, New Mexico, because the extreme exposure to that type of heat is not going to let my body acclimatize. So if you're going to be in extreme heat and doing activity especially, then you should try to acclimate your body to those conditions. Sunburn, again, I'm sure we've all seen one. I'm probably sure we've all had one. And even though, it's cold in the winter or maybe just spring, we can still see sunburn, even on cloudy days. So we always recommend, and all of our patrollers do, and always recommend to all of our customers that they wear sunscreen every single day that they're skiing, regardless of whether or not the sun is out. At high altitudes and snow and water, you actually increase your vulnerability to sunburn. So again, always wear sunscreen, and we recommend it to all of our customers. I think we know how to prevent sunburn, so we won't talk too much about that. But we always recommend to our customers that they wear sunscreen, cover up correctly, and then wear sunglasses, not only for sun protection, but for eye protection. Lightning is actually a heat-related emergency, as listed in the book. And it can be definitely, it's a life-threatening situation. 30% of lightning strikes result in death. And on average, there's 62 of those a year. So we can't predict where lightning is going to strike, but we do have good indicators that tell us when and where we should be. So we follow those very strictly on the mountain. It happens in the winter. It happens a lot in the summer, and we take lightning very seriously.
If you don't have it, if you get the app WeatherBug, it's got a feature in it called Spark. And most of us on the mountain are highly attuned to Spark because it shows you where the nearest lightning strike is.
I have I use WeatherBug even at home. Whether if I'm at a baseball game or a soccer game, I've learned to love my Spark.
And I think we use it more than we've got professional lightning detectors on the mountain, and everybody just uses Spark because it shows you the direction.
It's awesome. I love that app. Okay, so a lightning strike, if you don't see it happen, could look something like this. It can oftentimes have a fern-like appearance at the point of entry. So if you came upon someone and didn't see it happen but noticed this kind of pattern, that could be one indicator. It can cause an immediate respiratory arrest and cardiac arrest in addition to severe tissue damage. And that damage may not always be obvious. You may not see it, but but inside muscles and organs can be affected. Let's get through some of this. And again, it has a 30% fatality rate, so we don't mess around with lightning. So in an outdoor environment, one of the first and best things to do is to seek shelter. So if thunder, if you hear it, thunder, it's usually a good sign that it's time to seek shelter. So if you hear it, clear it, which means if you hear thunder, seek shelter. If you see it, flee it. So if you see lightning, get the heck out of there. So thunder, get to shelter, not necessarily take your time, but if you see lightning, get the heck out of there. Obviously, we'll clear ski lifts and any exposed structures that are out there. And the 30-30 rule, I think, is, and Jeff, correct me if I'm wrong, but if you if the time between lightning and when you hear thunder is less than 30 seconds, don't leave your shelter for another 30 minutes.
That sounds about right.
Yeah.
Yeah. I know we have an automatic 30-minute shutdown when it's within 5 miles. So that's
within
probably
5 miles.
Yeah.
Okay. Okay, so for any heat-related emergency, again, your standard assessment procedures would be to start with the ABCDs and vitals. Check their skin temperature and their appearance. That can give you clues as to whether you're looking at heat exhaustion or heat stroke. Check for muscle spasms or cramping. This can all be done through your sample. And then are there any behavior changes? Do you see any burns or do you see any trauma? So obviously the goal is to get the patient to a cooler or shaded area. Get them indoors if you can. If not, get them in the shade. And then monitor their vital signs as you go. Hydration and oxygen as needed. And then, of course, limit their re-exposure to the heat and sun. Recommend that they be done for the day, stay inside, or stay in the shade. Okay, any questions about heat-related emergencies?
Nope.
Okay, so now we're going to move on to plant and animal. This is a really, really long chapter in the book.
Yeah.
Because they go through literally every plant and every animal you could possibly think of, which is kind of scary. So make sure you look at your test bank questions for this chapter so that you don't, your brain's probably already overwhelmed, but definitely for this chapter, focus on your test bank questions because there's a lot of it. I'm sorry, go ahead.
Although, I think, I'll pull it up, but I did a analysis of the test questions and where they came from. I think there's maybe 2 questions from this chapter, maybe even more.
Okay, good. Yeah,
so
that's good because there's a lot of information, so it's kind of scary when you look at it. So similar to the other chapters, we're just going to walk through what they look like, how to assess them, and then how to manage them. So the skin has 3 layers. They've got the epidermis, the dermis, and the hypodermis. This is all in the anatomy section and covered again in your chapter 27. So just make sure you're familiar with the layers of the skin and their functions. That is sometimes on the test. And this is just really a demographic that shows, this is reddened, irritated skin, but it's a good graphic of the dermis, epidermis, and hypodermis. And when you're thinking about poisons, toxins, potential for infection, this just asks you to give thought of, organs with a high vascular supply, where your blood is going, like your liver, are going to absorb toxins rapidly. And then organs with a lower vascular supply, so think fingers, toes, feet, the extremities, increase the potential for infection. So again, it's basic anatomy and physiology, just thinking through things like that. So the distinction between a toxin and a poison. A toxin comes from a living creature, and a poison can come from a living creature or a non-living substance. So it could also be a chemical or man-made poison. And then venom, of course, is a toxin or poison that came from a specific animal like a snake or a spider. So these are 4 examples of plants that are toxic to the skin. It's not all inclusive. I believe we do actually have stinging nettle on the mountain. You won't see it in the winter necessarily, but it can be seen and affect people in the summertime. Long list of plants that are toxic to ingestion. Interesting stuff to read. Hopefully, I've never seen any of this on the mountain, and hopefully we won't have an occasion to. But my rule is if I don't know what it is, I'm not going to put it in my mouth, and I try to impress that upon my children as well. And then poisonous mushrooms. Who knew there could be so many, but there are. So be aware. There was a test question about little brown mushrooms at least on the test that I took. So again, maybe 1 or 2 questions total, but bugs, of course, are very prevalent, especially in the summertime. Up at Ski Apache, we see all kinds, spiders, ticks, don't see too many scorpions, but bees and wasps for sure, and then ants and mosquitoes. All things that people can be allergic to or can just cause a nasty bite. All kinds of reptiles that can hurt you. Lions and tigers and bears. This was just a picture. This is actually a dog bite on a child's face, just as an example. I think it's a sad little picture, but it does show the soft tissue damage that animals can do. So your assessment, again, you're going to start with the ABCDs and determine if this is a life-threatening situation. Was it a bite? Was it a plant or a large animal trauma? And if a patient's allergic to bees or ants or wasps, do they have an EpiPen with them? And do you see any bite or fang marks? If they didn't see the snake, do you see 2 puncture wounds in the skin somewhere? And then, of course, scene safety for yours and the continued safety of the patient. Make sure that the scene is safe. Is there an animal still there? A reptile still there? Can you move the patient away from the plants that maybe they fell on something? Can you safely get them out of there? So make sure your scene is safe, again, so you don't become injured yourself. And then observe standard precautions. Make sure that you're wearing gloves, pay attention to your surroundings, and again, call for support, advanced life support if you need it. Okay, I'm going to skip through those. Again, big chapter, not a lot of focus.
That was too slow. Do it again. Too fast.
Sorry.
Sorry. Yeah, I'm kidding.
Too fast. Okay, good. I was like, there's so much in that chapter. I just laugh every time. Okay, so
do you guys get on the snake bites with it?
Do we get on what?
Do you guys get on a snake bites up there in the summer?
No. I've never seen one there.
Never seen one. Never seen one.
Yeah.
You know, if anything, I would say, and I've never seen this either, but a lot of people bring their dogs. So, yeah. I mean, you never know when you might see a dog bite, a dog scratch, something. I've never seen it. Again, I've never seen it, but I'm trying to think of, you know, in the summertime there are mountain lions, there's bears, but I've never seen them.
There's most of our injuries in the summer are you get sunburn, heat exhaustion from the mountain bikers, and road rash from the mountain bikers.
Yeah.
And dehydration from the hikers that go up on the mountain with no water. And every so often you'll get somebody that gets into a patch of poison ivy, or there's this other one, something mustard, I think it is, that you get the oil on your skin and then it doesn't do anything until it's exposed to UV light. And then it gives you a terrible rash. So you get it in the shade, but then you come out in the sun.
Well, that's weird. I've never even seen that.
Yeah, it's something mustard grass or something. I forget.
Mustard grass. Okay, I'll have to look that one up. I don't remember it.
It's a nasty one. It gives you like a sunburn and then it blisters.
Ew.
Yeah. And then it starts to itch. Anyway.
No fun. Okay, so altitude-related emergencies. This one is something that we will see, as referenced by Becky earlier, quite frequently. So we're going to look at altitude physiology, why people experience altitude sickness, what are some of the issues that we might see, how we can prevent it, and then how to assess it when someone walks in or you encounter someone, and the best way to manage it. So part of our body's ability to stay in homeostasis includes the ability to adapt to altitude changes. So now living in Alamogordo, maybe you don't feel it as much, but I live in Austin at sea level. So it takes me a few days when I get there to kind of acclimate and feel semi-normal. on the hill. So you'll definitely see this because there's a lot of us Texans that come from sea level. We come fast and we ski the first day that we're there. So we're going to see a lot of altitude-related illnesses on the hill. So altitude is classified in different ways. So low altitude is considered less than 5,000 feet, intermediate 5,000 to 8,000, and then high altitude 8 to 12. So Ski Apache, I think, at the gondola top is 11,500 feet. Is that right, Jeff? Sierra, oh, sorry, I know you're on mute. So we're considered high altitude. So we'll see a lot of different altitude-related illnesses walk into the first aid room. So part of what our body does to adapt to the changes and kind of maintain that homeostasis is that it increases our respiratory rate and the depth of our respiration. So the body is saying, I need more, so I'm going to breathe faster and I'm going to breathe deeper. And your heart rate's going to increase because no, that's okay.
I cut myself off. I think 7,000 feet is where you start to get it, and 9,000 feet is where it really kicks in. Yeah,
and so I think Alto is like 7,000 feet.
Yeah.
The base of the mountain's probably 9.
Yep.
Yeah, the base of the mountain's probably 9,000 feet. So even at our base, at our first aid room, we're at 9,000 feet. So that's already high altitude just at our base. So these are things, again, that your body does to maintain homeostasis and help you get more craving. So what are some of the problems that we're going to see? The number one thing that I treat, well, it's probably close second with broken wrists, but is acute mountain sickness. So we'll talk about that. You're going to have a whole other session on oxygen, which will show you how to treat it. But acute mountain sickness is something that you'll see day in, day out at Ski Apache. We're also going to touch on high altitude pulmonary edema and then high altitude cerebral edema. Some of the other ones that you'll read about in your book are less pertinent and not something that you typically see, but they are altitude-related problems as well. So how can you prevent it? One, ascend gradually. So unlike those college students from Lubbock, Texas that get up at 6 a.m. and drive to Ski Apache and head straight up, that's probably not the best way to do it. So you should actually, ideally, come and spend a couple of days at altitude before you attempt any sort of exercise or vigorous activity. Realistically, that doesn't happen because, again, most people are on vacation. They want to get there and they want to ski.
We get people that drive all the way out from Houston and drive overnight and arrive at 5 a.m. and camp out in the parking lot and then go straight to the top.
It's crazy, but it does happen all the time. So ascend gradually. Avoid rapidly ascending. Again, most people at our mountain are not following any of these recommendations because they're on vacation and they're having fun.
You can go from 9 to 11,400 feet in about 15 minutes.
11. I was going to say 11 minutes on the gondola, right?
11, yeah.
That's so. Stay hydrated.
5 minutes on Tier 1.
That's true. So how do we prevent it? So, of course, acclimating your body would be ideal, but while you're on the mountain, again, and we give this routinely information to our patients, stay hydrated. You can't drink enough water while you're up there, so we encourage patients or customers to do that as much as they can. Avoid alcohol and other depressant drugs. Again, people are on vacation. We see it frequently. We serve alcohol on the mountain, but excessive alcohol can only make things worse as far as acute mountain sickness. And then high carbohydrate diet. Being at Ski Apache is not the time to go straight up protein. You definitely want to mix in some carbohydrates. Make sure your body has the fuel that it needs. And if you do have someone that comes in, we've got lots of, we've got water, we've got crackers, we've got oxygen, but they shouldn't be going back out and up until the symptoms have resolved. So again, when they walk in, we're going to do our assessment, ABCD sample, OPQRST. A lot of times when they walk in, sometimes you can take one look at them and know. They can be pale, nauseous. Oftentimes they're vomiting. They have vomited or they vomit while they're in the first aid room. They can feel dizzy. They can feel faint. I've seen one case of a poor young man. He was 28 years old, and he couldn't read letters on his phone. He was getting texts from his friends, and he couldn't read some of the, like he forgot what some of the letters were. Ultimately, he ended up being fine, but he ended up going home. So you can see it altered mental status in some cases. So the best way to cure altitude-related illness or acute mountain sickness is to go to a lower elevation. So once we've given them oxygen, given them water, they've rested, they've given it a shot. If symptoms don't resolve, sometimes we recommend that people just go down. Like, this just may not be your day. Try it again. High altitude pulmonary edema and high altitude cerebral edema. One is fluid in the lungs, and the other is swelling of your brain. Both of those can start out with symptoms that look a lot like acute mountain sickness, but can very rapidly progress to more serious symptoms. So if symptoms don't get better and symptoms or things start to get worse, definitely descend and possibly transport to a medical facility. All right, was that too fast?
Oh, that's fine.
Okay, so that was altitude. Again, it's one of the most common things you see. You're going to get a lot of hands-on experience with this. Last chapter is water emergencies. Again, not something that we see frequently at Ski Apache. We do have a pond that they use to pull water for snowmaking. Sometimes it's frozen, and sometimes in the summer it's not. Shoot, sometimes in the winter it's not. You could potentially have someone go into the pond, but these are good outdoor skills to have nonetheless. So we're going to look at the drowning process, dry versus wet, mammalian diving reflex, and then the gas laws. So again, I know you've already talked about respiratory related illnesses, so make sure that you understand oxygen transport and how that works and where it occurs. It's an important piece of information, and it'll definitely be in the test somewhere. So some common water emergencies are submersion, like drowning, near drowning, or secondary drowning, barotrauma, nitrogen narcosis, swimmer's ear, which we're not going to talk about, and of course there's animals that live in the water, so those can often cause injuries as well. So there are 3 types of submersion injuries: drowning, near drowning, and secondary drowning, and those can occur in any type of water, any depth of water. So this is just a little visual that talks about how submersion injuries occur. And then barotraumas are most common in scuba divers. So it can be decompression sickness and arterial gas embolism, or squeeze and reverse squeeze. So squeeze, pressure coming from outside the body and onto the body, or the reverse squeeze, pressure internally pushing out. So eardrum rupturing from the inside out or from the outside in. Teeth, sometimes pressure from the inside out. So different types of squeeze and reverse squeeze barotraumas. Breath holding. So a person may pass out without warning. And you see it a lot of time in children and young adults that are holding their breath for fun at the pool. Who can hold their breath the longest? I've done it a few times. And then, of course, trauma. What's in the water, under the water that you can't see, boating accidents, falls in or around the water. There can be so many different types of injuries in or around the water, probably too numerous to list. And then, of course, marine animals. They bite, they sting, they're big, all of those things. So you can see traumatic or toxicologic injuries in the water or around the water. So how do you prevent them? Of course, know your environment, know where you're swimming, know the water that you're swimming in, and never swim alone. And of course, alcohol around water is probably never a good idea. Use your personal flotation devices and never dive into water that you can't see the bottom of. So again, our assessments are always going to start with the ABCDs, and then based upon the situation that you're in, you can assess for a possibility or the signs and symptoms of an arterial gas embolem or decompression sickness, or the BINS, what they call it. And obviously in a water emergency, remove them from the water as soon as possible in a safe way that you as the rescuer will not then become a victim. Establish an airway, again, airway, breathing, circulation. And then transport all patients. Sometimes in a drowning or near drowning, symptoms may be, or secondary drowning especially, symptoms may be delayed. So I know this was definitely on the test and something we talk about, even if apparently dead, in a cold water submersion especially, they're not dead until they're warm and dead. So even if they appear dead in a cold water submersion situation, continue CPR. Okay, and that's water emergencies. Any questions?
Nope.
About any of the chapters? Anything specific? I know you have Facebook
Nope.
where you can do that. Okay. Okay. Well, thank you very much for your time. Best of luck to you. I'm sure I'll be on some of your other calls, but you sound like you know your stuff.
I'm working on it. Thank you.
There you go. Hey, Marissa, are you going to be there on Saturday?
Yeah.
Okay. If you ever can't make it, let me know because you're the only candidate. Our number 2 dropped out. So
oh man.
I know. So if you ever can't make it, let me know because I don't want the instructors to go out there and then nobody shows up. So.
Okay.
But, yeah, and I appreciate your response on Facebook. Thank you.
Yeah, I just noticed that. You're all set for this Saturday. Jamie will be there. Jason will be there. I forget who else, but I will not be because it's a long drive. But I'll be there.
That's a long drive.
Yeah, I'll be there the second session in June. So.
I think I will too, actually.
Okay. Oh, that's cool.
Yeah.
So anyway,
Thanks.
I guess that's it. I'll cut it off there.
All right. All right. Thanks, Marissa. You have a good night.
Thanks. You guys too.
Bye.
Take care. Bye-bye.
How do I shift?